invited us to. My name is Marjorie Scheikl, and I'm here with my colleague Kyle Pearson. We're nurses, and we work for VCU Health System in Richmond, Virginia. And we work in the OB Motivate Clinic and provide care to women with substance use disorders. The OB Motivate Clinic was created in 2019, and it's the only program in Central Virginia that provides integrated, co-located reproductive health services and addiction medicine to pregnant and parenting women. So a couple of things we like to accomplish today, and that would be to provide you with an overview of what addiction is, to have an understanding of the many risk factors that both development of a substance use disorder and a perinatal mood and anxiety disorder share. Being able to state interventions that are included in a harms reduction model of care, which our program is based on. And then also having an understanding of the recommendations for mothers who are caring for babies that are experiencing neonatal abstinence syndrome. And then, of course, we would like to leave you with some resources that we hope will be helpful to you as you move forward in your work with women. This is our program's mission statement. I'm going to read that real quick. The OB Motivate program strives to provide evidence-based, compassionate, person-centered, recovery-oriented, trauma and gender-informed care to people with substance use disorders across the life course, including during pregnancy and the postpartum period. OB Motivate Clinic values an integrated, multidisciplinary team approach to support families on their paths in recovery by helping families strengthen their recovery strengths while addressing their recovery challenges. OB Motivate also aims to educate healthcare trainees across medical fields in the neurobiological basis of addiction and recovery-focused approaches to substance use disorder treatment in order to equip the next generation of providers to be champions in combating the stigma surrounding addiction and its treatments, as well as expanding the capacity for high-quality care for people with addiction. And our program is multidisciplinary. We have 3 OBGYN providers, and they are also specialists in addiction medicine. We have nursing, social work, behavioral health counseling, and then support from our VCU injury and violence prevention team as well. Looking at a couple of statistics, and there's many out there, the Centers for Disease Control, or CDC, they looked at statistics on opioid overdose deaths in the United States from 2019 to 2020. Of course, this is going to reflect the opioid epidemic in the United States with the overlay of the COVID-19 pandemic that was going on as well during this time. And as you can see, the rates went up from 72,000 in 2019 to 93,000 in 2020. That's a 29% increase, which is huge. When you break down the numbers, that's like 250 people per day or 11 people per hour dying of opioid overdose death. The number of pregnant women with opioid use disorder has increased fourfold since 1999. That pretty much parallels the increasing problems with the opioid epidemic in the United States. And unfortunately, as recently as 2019, research has showed that only 1 in 10 women with a substance use disorder are receiving treatment. When Mandolin reached out from Postpartum Support Virginia and asked us to speak today, she did mention that there were facilitators in the Postpartum Support Virginia groups that had some concerns regarding women that possibly also were at risk or had a substance use disorder. And it really comes as no surprise when you look at what's involved in the development of both a postpartum mood and anxiety disorder like postpartum depression and developing a substance use disorder, because a lot of the risk factors intersect and overlap with one another. One of the things that I'd like to say first is that being diagnosed with PMAD or substance use disorder both involve a lot of stigma. They both have a lot of societal stigma. And unfortunately, we do know that stigma can prevent a woman from even getting care, or they might finally get care, but at a later than optimal time, which is unfortunate. When we look at the risk factors, the things that both of these disorders have in common would be things like adverse childhood events, having experienced intimate partner or domestic violence. We know that women who say yes for intimate partner violence have a 10% higher score for postpartum depression on our Edinburgh postnatal depression screening scale. Women who have experienced a traumatic pregnancy, labor, and delivery are at increased risk. They could have experienced miscarriage or a stillborn. They could have a child that is having an extra healthcare need, perhaps being in the NICU. All of those are risk factors for both of these diagnoses. In the social determinants of health, we have things like low socioeconomic status, low financial status, low education levels, housing instability. There are racial and ethnic disparities. For instance, in the substance use disorder research, we find that non-Hispanic Black women with substance use disorder receive less prescriptions for medication therapy than non-Hispanic white women who have substance use disorder. And we don't know why we have that disparity, but it does exist. Then we think of things like relationships, people that have experienced poor support and stress in their personal relationships with their own parent, or perhaps their partner, that puts them at increased risk. Having a history of depression or anxiety puts a woman at risk as well for developing these problems. And then as far as social determinants of health, we have things like housing insecurity, financial instability, unemployment. And then specific to the postpartum time period, we have women who are not getting enough sleep. They are don't have enough support at home, and there's just that increased stress that goes along with parenting. So lots of intersection and overlap. When it comes to the postpartum time period, that is a super critical time period when it comes to substance use disorder, because the research has shown that women are more likely and have a higher rate of overdose between 7 months and 12 months postpartum. So that's huge. So the postpartum time period is a critical time period when it comes to preventing death. And for that reason, it is recommended and evidence-based that women who are on prescribed medication therapy for substance use disorder maintain their medications during that first full year after giving birth. Here we have the definition of addiction from the American Society of Addiction Medicine. And I just want to point out some of the big things, which are it is a chronic disease of the brain. Over time, there is deterioration of parts of the brain that are responsible for things like impulse control, behavioral response to stress, and being able to make good decisions. Like other chronic diseases, addiction does involve cycles of relapse and remission. And I liken it to another chronic disease that a lot of people in the United States are very familiar with, which is diabetes. A person with diabetes has a treatment plan. Usually that includes something like being on a special diet, maybe an exercise regimen. They might be on some type of PO pills, medication, or even injectable insulin as needed. They periodically are going to be evaluated by their provider to see whether or not their treatment regimen is keeping their blood sugar or blood glucose levels at a stable level for their health. And if they are found to have a blood sugar level that is way too high or way too low, that's not healthy, then that treatment plan is definitely going to be changed. The same thing goes for somebody diagnosed for substance use disorder. They have a treatment plan. Usually that involves things like counseling. They might have group therapy. They might have parenting skills. They might also be prescribed some type of medication. They also might have medications for their mental health. They periodically come in, they're screened to see whether or not the plan of care is keeping them from using an illicit substance or a substance that is harmful to them. If the treatment plan is not reaching that goal, then the plan would be changed. Here's a snapshot of the neurobiology of addiction. It starts with a person experiencing some type of discomfort or pain that could be emotional, it could be physical, it could be both. This is written specifically for opioid, but it's very similar with different neurotransmitters for different substances that people would use. So a person would use an opioid, such as a pain pill like Percocet or Oxy, or they might have heroin or fentanyl that goes to the brain. It reaches the receptors in the brain, and that triggers something to be released called a neurotransmitter. And in this case, that's dopamine. And dopamine makes a person feel great, right? It does a couple of things. Dopamine does produce euphoria in the body, so they feel well. It takes away pain signals, so they don't feel pain, which is wonderful, and they feel great. And then it also, though, in another part of the brain, these signals start to come out saying, that feels great, do that again. So the brain is sending out these signals from a different part of the brain saying, this was a good thing, this was a good thing, do this again. One of the other things that happens, which is very dangerous, is that the brain might not recognize that the body needs to breathe. And so a person's respiratory rate might slow down, or it might completely stop. So once a person uses the drug and then they have this response and then they get these signals from the brain saying, that was great, use that again, the person's going to try to secure the substance and use that substance again. But unfortunately, each time they use it, the brain becomes less sensitive to the substance so that they're not going to get that rewarding feeling of euphoria and pain, masking of the pain that they got originally. However, the signals become stronger and stronger, saying, I want to feel like that. That's what I need. Use that. And so despite the person using the substance, they're not going to get the rewarding feeling. And over time, they're just going to be needing to use the substance so that they don't feel the negative symptoms of not having that chemical in their body. And those are called symptoms of withdrawal. So how is a person actually diagnosed with opioid use disorder? There are 11 diagnostic criteria. They do need to have a minimum of 2 to 3 of these to be diagnosed with an opioid use disorder. 9 of those criteria are behavioral. And those are things, I'm not going to go through all of them, but those are things such as wanting to stop, trying to stop, and not able to stop using the substance, continuing to use a substance despite the fact that the person themselves may be putting themselves in danger, or continuing to use a substance despite the fact that it's interfering with the person's ability to work or have a good relationship with their partner, that they continue despite these negative consequences. The 2 physical criteria we talked about, one is tolerance, and that is that over time, the person is using the substance, but they're not getting the response that somebody who wasn't tolerant would get. So they're not getting the euphoria, they're not getting the pain relief. And then the other physical criteria would be withdrawal. And that is, if the body doesn't get that chemical substance, the body experiences physical symptoms of withdrawal. So our program is based on a harms reduction model, and a harms reduction model means that we would follow policies and practices that support anything that is going to lower the negative consequences of substance use disorder. And so here is a list of things that are included in a harms reduction model. Person first language, which is the way that we talk and describe a person with a substance use disorder, using something called person first language. We have found through research, words truly do matter in that it takes away some of the stigma surrounding substance use disorder, and it can actually alter not just the way that the patient themselves feel, whether or not they're being perceived or judged, but also the way healthcare providers deliver their care changes based on the language used. Narcan is something that we do like to have all patients have and have an understanding of how to use that. That would be something that a person would use if overdose occurred and breathing stopped. Medication for opioid use disorder is a harm reduction strategy, and medications that we use are things such as methadone or buprenorphine with or without naloxone and naltrexone. People who are using drugs that require syringes, they often can get infections such as HIV. And so people that are doing that can reduce harm by using needle exchange programs and getting sterile needles and making sure that their needles are clean and that they're not sharing with others. Safe use of drugs, there's two things in that regard. One would be having a patient, if they are taking a drug off the street and they're telling you that, having them test that dose before they take a full dose, because a lot of the drugs that a person thinks they're getting all kinds of things mixed in, and it's very dangerous. The other thing is to use in groups or to have a person always know when a person is going to be using a drug, and that way they have somebody there or somebody that can check on them and see whether or not they could possibly need Narcan and need 911 to be called. Individual counseling, as well as support groups like Alcoholics Anonymous or Narcotics Anonymous and other supports, are very beneficial and help to round out the treatment plan. There's usually a co-occurring mental health disorder that goes along with substance use disorders. And then just being able to provide people with a way to find treatment. And there is this one link, findtreatment.gov, that is really super easy to use. A person can go to that on their smartphone or their computer, and they just plop in their zip code, and they'll get all the different programs located near them and what those programs provide. I have left a handout with you all that you can take today. It's called Your Words Matter, and it was put out by the National Institute of Drug Abuse, which is under the National Institute of Health, or NIH. And it talks about person-first language and how to utilize that. And I took this just snippet to put up on the screen to give you an idea. It's a really great form, it's very user-friendly. You can see on the left side, they have different labels that are commonly used when referring to people with a substance use disorder, such as a substance or drug abuser they have here. And then in the middle, they have what are other ways that I could describe a person other than saying a drug abuser. And they have different things over here, like person with an opioid use disorder or person with an opioid addiction. And then all the way to the right, they have the rationale. And the main thing is that it avoids eliciting those negative associations that come with certain words. If we say the word abuse or abuser, that typically drives a negative connotation, and that does impact not only the way the person feels and whether or not they're being judged or perceived, but also in the actual care that the healthcare provider gives. They have done research and found that the language used is very important. And I'm going to hand things over now to my colleague, Kyle Pearson. She's going to talk a little bit about the newborns.
Yeah, well, thank you all so much for having us. I just want to say my background is working with newborns in the neonatal ICU at VCU. So when I joined this team, I had previously been taking care of newborns, and now just feel very fortunate to be able to take care of women and their babies. So we're going to talk a little bit about newborns who have been exposed to substances prenatally. So you might hear a couple of different terms regarding newborns that have been exposed to substances. One is neonatal abstinence syndrome. And this describes a group of physiologic and neurobehavioral signs of withdrawal, and we'll talk about what those are in a few minutes, that could occur in newborns that have been exposed to substances prenatally. And when we say substances, that could be prescription drugs that we prescribe them, such as Suboxone or methadone. It could also be illicit substances like heroin. And that also includes marijuana and alcohol. So that's neonatal abstinence syndrome. There's another newer term, NALS, which is neonatal opioid withdrawal syndrome. And that basically is just used to describe opioid-only withdrawal symptoms that are exhibited by newborns who have been exposed to opioids prenatally. In the literature and in clinical practice, you'll hear the term NAS or NAS, some people say, more typically, just as an all-encompassing term instead of NALS, because newborns that are exposed to substances prenatally frequently are exposed to multiple substances instead of just opioids. So Margie's going to control the screen for me. Thank you. So these are some symptoms of NAS, or neonatal abstinence syndrome. So under the neurologic symptoms, excessive crying, irregular sleep patterns. Sometimes it can just be challenging for babies with neonatal abstinence syndrome to get good sleep. Tremors or irritability, skin breakdown. And skin breakdown commonly happens because the baby might be upset and sort of rubbing their elbows or their knees or their face into the blanket or whatever surface they're laying on. So that's why skin breakdown can happen. Increased muscle tone, jerks, and then seizures would be one of the worst case scenarios. That is not something that frequently happens. So that would be something that we're looking for, but definitely doesn't happen frequently, thankfully. Then under the gastrointestinal symptoms, excessive sucking, poor feeding, vomiting, diarrhea, and poor weight gain. And then other symptoms are sweating, low-grade fever, nasal stuffiness, tachypnea or increased respiratory rate, and then mottling of the skin. So those are the symptoms of NAS. Margie can advance. So how frequently does this occur? So about 50 to 80% of newborns exposed to opioids prenatally develop symptoms of NAS. That doesn't mean that all of them need to be treated for NAS, but they just might have some symptoms from the list that we just reviewed. So symptoms of NAS in the newborn can develop within 24 to 96 hours after birth. So it's recommended that newborns who have been exposed to substances prenatally are monitored in the hospital for at least 4 days after delivery to make sure that they're stable and not developing worsening signs of NAS or neonatal abstinence syndrome. So other impacts of neonatal abstinence syndrome. Symptoms of NAS are worse frequently with polysubstance use. So when mom's using more than one substance, and that does include tobacco and alcohol, which we'll talk about a little bit more within the next few slides. Also, this includes, like I said, prescription medications like some antidepressants, SSRIs like Zoloft, benzodiazepines. So a few of the medications that you'll frequently hear of women being prescribed who are in substance use disorder treatment would be Suboxone, which is also buprenorphine, naloxone. And with Suboxone, symptoms of NAS in the newborn might be milder and have a shorter duration than with methadone. And there is no evidence that Suboxone causes birth defects, and it has minimal long-term neurodevelopmental impacts. So that's one thing that we want to talk to our patients about. We frequently will inform them that based on their particular situation, the benefits of pharmacotherapy for opioid use disorder during pregnancy can outweigh the risks of not being treated for opioid use disorder. Like Margie was talking about overdose previously. So that's a conversation that we frequently will have with our patients. And then methadone is another prescribed medication that you'll hear of women with opioid use disorder being prescribed. With methadone, the duration of neonatal abstinence syndrome is longer than Suboxone. So babies might need to be hospitalized for a bit longer to receive care for their neonatal abstinence syndrome. And again, there's no evidence that methadone causes birth defects, and it has minimal long-term neurodevelopmental impacts. And one last thing with women who are being prescribed medications for opioid use disorder, we would just always want them to know, and I think this is important for people who might be taking care of women with opioid use disorder, that the dose of medication does not impact the risk or severity of NAS. So with that being said, maternal dose should be titrated to control mom's symptoms of withdrawal and limit cravings. I think sometimes frequently women will want to be on the lowest dose possible because they think that the lower dose will have less implications for their baby and neonatal abstinence syndrome, but that is not the case. So that's another point of education that we'll frequently provide our patients. So go to the next one. So screening tools for neonatal abstinence syndrome. So these are tools that we're going to use in the hospital, in the newborn nursery, and in the neonatal ICU to assess babies. So this would be prior to diagnosis of neonatal abstinence syndrome, and then we would use this throughout their care. So Finnegan is an assessment tool that is commonly used, and it assesses symptoms of NAS and NALS. It's a little bit complicated. It assesses 21 symptoms. It can be very subjective based on who is observing the baby, what they see. Two people might do the tool at the same time and get a different score. So that is one of the downsides of using the Finnegan tool. But it's a numerical score that's based on observed symptoms of NAS. If newborns exhibit consistently high scores, which usually will mean more than 2 in a row of a high score, which is usually greater than 8, then pharmacotherapy is recommended. So usually we're using this tool every 3 to 4 hours to observe the baby and provide a numerical score. So that's the Finnegan tool. A newer model that has been used at our facility at VCU more recently, within the past few years, is something called Eat, Sleep, Console. It evaluates just 3 elements in the newborn. So it's the newborn's ability to eat 1 ounce of milk or breastfeed well, sleep undisturbed for 1 hour, and to be consoled within 10 minutes. So the nurses that are taking care of, nurses and providers that are taking care of babies with potentially developing symptoms of NAS will monitor them for just these 3 elements. And if they are not able to eat well, sleep, and be consoled, then the team has an interdisciplinary meeting to discuss changes that can happen with the non-pharmacologic interventions. So is mom or dad, is the caregiver, able to hold the baby so that the baby can potentially get some good rest? What else can we do? Can we get the baby in a quieter environment? So there's just more questions that you're going to ask before you would initiate pharmacotherapy for the baby. And using this tool, the Eat, Sleep, Console tool, has decreased the need for newborns to have to start pharmacotherapy for neonatal abstinence syndrome. So it's definitely been a great tool that we're happy to use at VCU. So treatment options for neonatal abstinence syndrome. So with the Eat, Sleep, Console tool, non-pharmacologic interventions are very important. Parental and caregiver involvement is the key to success. So that's something that we want moms, dads to know, that they're a huge part of their baby's care team. So we would encourage them to room in and stay with their baby as much as possible. Because like I said, we're going to assess these babies in the hospital for 96 hours at least. So mom might already have been discharged, her postpartum period in the hospital might already be finished. So we would ask for mom, dad, caregiver to stay with the baby while the baby's continuing to be observed. So another non-pharmacologic intervention would be to feed on demand. Right when the baby starts to wake up and move around, maybe the baby starts to suck on their hand, or making the rooting reflex, we would want to feed them right away. And we would encourage breast milk if appropriate. So just as a side to that, breastfeeding is encouraged for newborns who have been exposed to opioids prenatally. However, it is not indicated if moms continue to use illicit substances. But if they're in a medication-assisted treatment program, they're being prescribed Suboxone or methadone, we would definitely encourage them to breastfeed. Other non-pharmacologic interventions would be to console the baby quickly. Swaddling, skin to skin, pacifier use are all great ways to console newborns. And then to limit environmental stimulation. So preferably if mom's able to room in, we would have the baby be in one of the postpartum adult rooms with mom. And so not necessarily in a newborn nursery where there's a lot of people and maybe other babies coming in and out that are, making noise and causing disturbances. I know in our nursery at VCU, we use sound machines. They do have some cribs that move in order for the baby to be rocked in the crib. So those are ways that we try to limit environmental stimulation in our nursery. So then if a pharmacologic intervention is required, so if our Eat, Sleep, Console tool, baby's scoring high and we're not able to console the baby, feed the baby, get the baby to sleep, then we would consider using opioid medications. And they would be initiated if the baby's consistently demonstrating symptoms of NAS despite appropriate non-pharmacologic interventions. So the next slide is on the benefits of breastfeeding, which I kind of touched on that a little bit, but breastfeeding can decrease NAS severity. It can reduce infants' need for pharmacologic therapy and decrease length of hospitalization. We know that a little bit of the substance does go from mom to baby. So that's why we would not encourage a mom who's using illicit substances to breastfeed. But if mom is in a treatment program and receiving Suboxone or methadone, we know a small amount of that might go to the baby, which is why it would help a little bit with the NAS symptoms. So in our clinic, our pregnant moms are encouraged to schedule a prenatal appointment with our pediatric nurse practitioners, who are also lactation consultants who work in our newborn nursery. So they're going to be taking care of babies who have been exposed to substances after they're born. So moms get a chance to meet them before their babies are born and discuss NAS symptoms, management, and the benefits of breastfeeding. So that's a really great consultation that many of our moms take us up on. And I think that they feel good about having that knowledge. So now to move on to alcohol exposure prenatally. So we know that alcohol exposure is known to cause birth defects. So fetal alcohol spectrum disorder is a group of conditions that can occur in children who have been exposed to alcohol prenatally. With alcohol exposure, this might not be something that you're going to see right away, the children exhibiting these symptoms, but but it could be diagnosed within 4 years of birth. So the most severe form of fetal alcohol spectrum disorder is called fetal alcohol syndrome. And some of the symptoms with fetal alcohol syndrome are poor growth, abnormal facial features, behavioral disorders, poor coordination, and then impaired intellectual development. So we know that no amount of alcohol is safe to consume during pregnancy. And this can be a little challenging because frequently women might not know that they're pregnant for a while, and especially in those early weeks of pregnancy when so much is happening, so much development is happening rapidly with the baby. The alcohol exposure then can be particularly detrimental. So that is another reason why we encourage means of birth control and definitely provide a lot of education to our patients on that. So that's alcohol exposure. And the next slide is on nicotine exposure prenatally. So adverse impacts of nicotine exposure can be on the fetal brain and lung tissue, and they can have long-term developmental effects. If a mom is using other substances and also using nicotine, we know that that can cause more severe symptoms of neonatal abstinence syndrome. And some of the complications that you might see with nicotine exposure prenatally would be premature birth, low birth weight, lower APGAR scores, which is a score that's assigned right after birth, that's looking at how the baby breathes, their heart rate, their color, their tone, and then an increased hospital length of stay for neonatal abstinence management. And I didn't write a slide on this, but just to touch on marijuana briefly. So symptoms of marijuana that we know can happen with a newborn if they're exposed prenatally would be lower birth weight, again, prematurity, behavioral problems, intellectual delays, and then potentially ADHD and ADD. So marijuana is also not advised in prenatally. So legal implications of pregnancy and substance use disorder. So legal consequences may be a barrier to care for pregnant women with substance use disorders. And so providers should be transparent with their patients and provide prenatal education on the necessary postnatal referrals. So what I mean by that is what reasons why we would have to refer the family to Child Protective Services, which ultimately the goal of a CPS referral is to strengthen and support families and babies and to make sure that everyone's safe. But we do want to be upfront with our patients about that. One tool that is used, and actually CPS frequently requires this, is a plan of safe care. So our social worker in our clinic will help our patients to write a plan of safe care. And the purpose of that is to ensure the safety and well-being of the newborn who's been exposed to substances prenatally, but it also outlines the health needs and the substance use disorder plan for the parents and the caregivers. So that's something that we would typically do within the 3rd trimester of pregnancy for our patients who are receiving prenatal care and substance use disorder care with us. So I think, yeah, I think that's it for my neonatal abstinence portion.
And here we just have a list of patient resources. And we also gave this as well to Mandolin to provide your group. And then a little bit about our clinic as well, in case somebody would like to refer themselves or somebody else to our clinic. We included that as well. And references. And yeah, do you all have any questions that we might be able to answer?